everybody, this is Dr. K from Holistic Minds. Today I'm really happy to be introducing Dr. MaryAnn Magoun. She's not only a friend, she's a brilliant pediatrician and one of the top osteopaths that I know. And to say that she works miracles every day, I think is an understatement, but she really does. So we've known each other for how long now? It's been over 10 years?
At least. We were at the medical school together. Yeah. We were at Loma Linda together.
So 2003.
Yes.
Jesus, it's been a while.
15 years.
It's been a few days.
Yeah.
It's been a few days.
And it goes by so fast.
It does. You're an osteopathic physician. You do traditional cranial osteopathy. And I think this is an area that most people don't even know about. So why don't you share a little bit about yourself and who you are, what you do, whatever you want the audience to know.
Okay.
And then let's get into it.
All right. Well, above all, I am a physician. I'm a pediatrician, and my goals are to help children be their maximal potential and reach this. And as an osteopathic physician, we look at, because everybody says, what is osteopathy? And so it's a philosophy. It's a philosophy of wellness. It's integrating mind, body, and spirit, and it's looking at everybody, be they an adult or a child. It allows them to look at the person and figure out how we can help them go through life and their journey through our life as a healthy individual. So we're integrating that mind, body, and spirit, and by looking at structure and how the body works as a whole unit, we can help facilitate that. And it's predicated on this interrelationship between structure and function that we predicate our rationale for treatment.
And
basically it.
One of the things I remember, so I was working as a student with Eric Dolgen, another osteopathic physician that works a lot with children. And one of the things that Eric said early on when I was a third year student, I think with him, was like, don't look so much for the restriction, look for the health. Help the health reach its optimal potential. If something is blocking the health, figure out how to get rid of that blockage and ultimately allow the health, the intelligence of the human body to express itself.
Exactly. So in that intelligence, the body is actually capable of self-regulatory processes and self-healing given the optimal circumstances. So that's what we basically do. For example, if we have a child that isn't meeting developmental milestones in a timely fashion, there's usually some kind of structural restriction. And by releasing that, the child then proceeds to meet those milestones and become the best version of themselves.
Amen.
Yes. So
now, when people think of restrictions, they think like their neck is kinked out, or the other day I was cycling too much, so I had one of my vertebrae literally like poking out, and my wife is like, you look like the Hunchback of Notre Dame, because literally there was like bone sticking out. So I mean, those are the obvious restrictions, right? And that's when the chiropractors go in there and go, and they pop something back in.
Right.
But there's restrictions that are not a bone sticking out of place. I mean, that could be a sign, but there are restrictions that are way more subtle than that.
Way more subtle. So a lot of them, I mean, we look at the structure, we look at the bony structure, the skeleton and the appendages, but then we also look at the arterial blood flow that's bringing nourishment to all the tissues, and we look at the venous return and the lymphatic return, and then the nerve innervation to every part of the body. So if you have an obstruction here, and you've got muscles that are very tight and they're torqued, they're encased by fascia, and if it gets torqued, you're impeding arterial flow. And so sometimes you're not able to use your hand and hand muscles efficiently. So by releasing all of this, you get better innervation here, and you're able to do a lot more, be that you an adult or a child.
Awesome.
Yeah.
Now, you said something, you said fascia, and I think most of the population has no idea what the heck fascia is. So if I remember back in the osteopathic medical school days, it's basically the elastic tissue that keeps us together, because without fascia, we just fall apart.
Right.
Right?
So we have a bony structure. Everyone's seen a skeleton, Halloween, Coco, the video Coco. And then we have fascia, which is continuous from the head to the toe. And it encases all the muscles throughout the body. So it actually holds the skeleton together. And if you've ever gone to the grocery store and you bought a package of meat, that cellophane wrapping is analogous to fascia, only the fascia in the arm is connected to the collarbone, the clavicle, and on down the body. So if it gets torqued and it gets very dry, you can have dysfunction and you can have pain and what we call somatic dysfunction.
And everything is tied together.
Everything.
So you can have a tweak in your ankle, which then causes something in your back to go out, which then causes a problem in your arm, which then causes something else, because the human body is one whole.
Exactly. And so we even look at the way people walk. And when you've got diminished arm swing on one side, sometimes it's coming from your back. It's the thoracolumbar fascia. And so you know the restriction might not be in your arm, even though you're having neck pain or shoulder pain. It may be coming from your lower back. Or you picture a child that all this fascia is bound up, and if it's so tightly bound and their back is very straight like this, they can't bend forward. And so they're not able to crawl efficiently and then pull themselves to a standing position. And so their gait, as they learn to walk, is abnormal. And they either teeter, totter, they're off balance, they're falling a lot, etc.
It's all of these little things that we never pay attention to, right? I think I've been lucky enough to be surrounded by osteopaths like you, like Dr. Gill, Dr. Dolgen, you know, and through all of you, I've learned so much. And as a pediatrician, like it's fascinating for me because I'll watch the infant crawl and I'm like, well, why is that left leg just kind of dragging along, you know? And sure enough, after one treatment, all of a sudden, you know, the infant starts crawling, or the kid that's got a little bit of a wobbly gait, you know, they get treated and all of a sudden the gait straightens out. So all of these little things that we call normal, because I think if you don't understand these pieces, right? If you don't understand how everything is tied together, you don't know what else to call it, right? So when we look at something and it's like, well, the leg isn't broken, you know, the hip looks okay if you did an x-ray, so therefore it's normal, is actually not normal.
It's not normal. And remember, in medical school, we're taught to be the masters of observation. We can pick out asymmetries in the orbits. We're taught and trained, and have timed exams, like the level of the earlobes versus the level of the eyes versus the level of the shoulders versus the level of the hips. And we can pick that out a mile away. We watch patients walk into clinic and we think, here's a part of the body that's not moving. So that tells us maybe where the problem is, but we're using the rest of the body and the inherent health to bring it back into balance. And that's, I think, what you were referring to with Dr. Dolgen, is seek the health because it's there and because the body has this ability to self-regulate. It just takes a little bit of tweaking, or it takes a lot of treatment, depending on the processes which brought it about. Sometimes it's genetic, sometimes it's the baby's positioning in utero, sometimes it's the forces of labor or delivery, or even a difficult C-section. Everyone thinks, oh, that's just an easy thing, but they put an awful lot of traction sometimes in pulling out the head. And so it creates problems throughout that fascial web, as we call it, that the whole body. And so even from the time a baby's born, you can see little asymmetries. And the most important thing that we do is we can palpate them with our hands. We have receptors in our fingertips. We can palpate in the palm of our hand up to 40 micrometers, but in the pads of our fingertips up to 10 micrometers.
You can feel 10 micrometers of
pressure.
That's nuts.
And that's an infinitesimally small amount, but with a lot of training and years of experience, we're able to feel that. And they've actually done physiological studies to substantiate the claim.
That's crazy. It's not crazy, it's amazing, is what I... So I think this is a part that a lot of people will be really surprised to hear. Because, you know, we think of birth as just this natural, easy process, right? Baby comes out, baby's breathing, no, everything is fine, and therefore it's okay. But I've been humbled to realize, I mean, it happened with my own daughter, right? When we really think about it, so you have this elastic tissue in the body, it stores energy, right? If there's any trauma of any sort, it goes in there, and basically it's energy stored in the body. And then we think about the birthing process, especially if we use Pitocin to really push the baby out, or you've got the OB yanking on the baby. It's not the most gentle process.
And it's not natural, and it's 100 millimeters of mercury in this rotational force. And if it's been augmented by Pitocin, it's even more than that.
So wait, 100 millimeters of mercury, what does that translate into?
Pounds per inch.
Okay, so
like your car, your tires on your car should be 30 to 40.
So it's basically 3 times the pressure that is on each tire is going into the baby.
Right. It's a rotational force that squeezes the uterus. And the baby has a very plastic body. It's very compliant, so things can contract. That's why the bones, everyone's familiar with head shapes and sutures and soft spots, so to speak, fontanelles as we call them. They can override so the baby can fit through the process. The ribs, not many people think about this, are very compliant. They're mostly cartilage. And they're oriented horizontally for that ability to collapse and squish coming through here. Otherwise, if they were more like adult conformation, we'd have big chests and everybody delivered by C-section. So it has to be able to come, but then the key part is after all of this is squeezing through there, and some of it's physiological, it's squeezing out all the secretions and the amniotic fluid that they've swallowed in utero, but they have to have, and the most important part is that initial big first breath of life, which is going to re-expand the cranial bones, re-expand the rib cage, and therein lies one of the big problems, is that they're not able to get that big first breath, or it's only one side and the other side stays compressed. And so this is a big part of the problem. So it looks like they're breathing, they're saturating, they're pinking up, but there's asymmetry. And the body loves symmetry. And newborn babies, it's the only pattern they know is the one that was set in utero. They're like a tabula rasa in psychology. It's like a blank slate. And all they know is the pattern that they're born with. Some of them are able to re-expand, and it's fine, but others not. And so oftentimes it will accentuate. That pattern will, as they get a little bit older, will be reinforced. And it will become more obvious to parents and other people that there is this asymmetry. And sometimes it's in the orbit. So one eye's bigger than the other, one eye is a little more closed. Or leading into the next thing would probably be, you'll see abnormal behaviors. You'll see.
Well, let's talk about this, because you just kind of shared all of this thinking like this is obvious to everyone. I think it's obvious to you. Sometimes it's obvious to me, sometimes not. But for most of our audience, I think most of what you shared is actually not that obvious. So, for instance, like I've had kids come into the clinic and they have glasses, and like there's a little guy that I take care of, and he actually had craniosynostosis where his bones were stuck together. So the plastic and neurosurgeons did an amazing job. They reconstructed his skull and so forth. But I looked at his face and I told the parents, I'm like, has anyone pointed out that his eyes are actually offset? And they kind of looked at me, and they've seen ophthalmology. They've seen the best of the best across the country. Like, we're not talking like, that this was some Joe Schmo that took care of this guy. But everyone was focused on their own field, and somehow along the way, no one noticed that this child's eyes were actually offset by several millimeters.
Right. So the offsetting can actually come from that cranial bone structure, because at birth and even into young childhood, everything is connected by sutures, and a suture allows for movement. And so sometimes one orbit will be a lot bigger, or one will be more prominent, and it will be what we call in the cranial world more internally rotated, like brought in. And so that's taking it forward, and this is the offset phenomenon that you're talking about. And the other will be very flat. The orbit will be flat and a little posterior. And usually the one that's more forward is the dominant eye. Huh. And you can actually, you can work with prisms, as Dr. Sperling probably addressed, but you can also take the dural, okay, so this becomes part of this fascia that we talked about.
Yeah, the plastic tissue.
Continuous and encases the spinal cord, which is actually a really tough, tenacious kind of fascia called dura. And the dura encases the entire brain, but it also encases each cranial bone. We call it periosteum. Whatever, it's all connected. And so the dura can move as a unit and help expand, and it can be expanded and it can be compressed. Compression's never a good thing. You want equal expansion, so we can actually work with our hands to take that orbit that's a little bit recessed and get motion into the bones, which will actually help make the contour more symmetrical. Huh. And thereby improving the visual acuity or whatever the visual disturbance is. Because this dura, this is the interesting part, is the dura is actually continuous with the fascia of the face and the sclera of the eye.
No.
Yes. So it's exciting. It's anatomy, normal anatomy. So you have the optic nerve coming through the optic canal, and right where it comes into the eyeball, so the optic nerve is what allows us to see and process vision. There are a lot of fibers going through it, and then there's dura, and that break point, right where it becomes the eyeball, it becomes the sclera. So sometimes if the dura is twisted, the eyeball gets twisted.
Wow. Well, because everything's connected, everything's tied to one another. So a tension in one area can totally mess up something else, including the eyeball. Mm-hmm. And I think this is the part that people would trip out over, because, we're taught that, well, the skull is this hard thing, everything is just constant and nothing can move, but that's actually not true.
Right.
You can actually, we're talking millimeters of movement. We're not talking cracking the skull in a direction, because you probably wouldn't want to do that, right?
Because all of these sutures are made up of what we call, it's dense connective tissue, or Sharpie's fibers. And that allows for a wee bit, like we're talking millimeter of motion, but we've actually shown this in functional MRIs. And so they can actually measure in some of the images, the skull bones will be expanded and the diameter will actually be a few millimeters in difference.
Wow.
And so that's a really neat thing. Now, going back to this asymmetry, how does it present in an infant? How does it present in a young child? Is they've got depth perception problems. And when they've got these depth perception problems, the gait is altered. Otherwise, they'd be tripping, falling. So they tend to widen their stance, and the whole body has to adjust. Sometimes they're walking on their toes to compensate. Sometimes they're walking back on their heels. Those that are toe walkers are then, the legs are going to start getting tighter muscles and contractures, and those that are on their heels are going to be falling on their bottoms an awful lot.
And I guess there's so many rabbit holes we can go down in terms of how structure impacts the child's function. Mm-hmm. Let's kind of back off a little bit. Let's kind of zoom out, because one of the things that I believe and I've seen is that a good at least quarter, if not a third, of the kids that I see with gnarly behavioral issues have some kind of restriction. And a lot of these restrictions probably go all the way back to birth, and because no one is talking about this, and that's one of the big problems. We've got brilliant docs like you doing your work in the osteopathic world. Everyone's talking with one another, but part of why I'm so happy that you're here is because I want you to share your truth and your knowledge and wisdom with the world, because people need to know about this. And I, as an osteopath, not that I practice it, but at least I know what it is, can see how a traumatic birth, issues early on, God knows what else, caused strain patterns or tightnesses, let's say, restrictions in the body. And then now we've got this 6-year-old that is having ADHD, anxiety, OCD, whatever, fill in the blank. And in at least a third of these kids, I believe that it ultimately boils down to something structurally being off. Their eyes are off, other things are being off. What has been your observation? Because you work with a lot of children.
A lot of, this is my practice, is a lot of ADHD kids, children with emotional problems or emotional lability. They have meltdowns. And they don't really fit the criteria for being on the autism spectrum, but they have, and I just see this every single day in so many children, is sensory integration problems. So if they're getting overload from the visual senses, the auditory, taste, whatever, everything integrates in the area of the brain deep down inside called the thalamus. And it has to be a smooth, and this also integrates with physical, like moving your arm back and forth. And so the mainstay of treatment is to allow the processes to come in to make sure structurally and functionally, but to integrate them. So here's something really interesting. So children, like with cross-eyed, with strabismus, it's kind of, they can't process things visually. And it goes back to when they're learning to crawl. And they should be, when they're learning to actually creep on hands and knees, they have this contralateral crawl. They need to establish the pattern because it goes through an area of superior colliculus in the brain. And that's getting gross motor function tied in with the vision. And sometimes they miss that stage. And so if they miss it, they'll make maybe 3 or 4 sounds when they're crawling along the floor, and there should only be 2 distinct sounds.
Because the brain isn't integrated. So
it isn't integrated.
They never wired correctly.
Exactly.
And you know, it's funny you bring this up because there's so many people out there that are saying, "Oh, crawling isn't important. Crawling is something we can skip." You know,
right,
just
we're
put
going
the kid,
to stand.
Yeah, just put the kid in the walker. But it's actually important.
It's important for their development. And the good thing is, you can, even as an adult, you can go and be on the floor and work on crawling, and you'll find that words are no longer skipping around on the page.
Crazy.
Something Dr. Fryman actually did a workshop for us. She's a well-known, she's now, she passed away 2 years ago, but she's one of the premier osteopathic pediatricians in the world. And so she taught and was a mentor to many of us. But she would show us this, and she had us crawling on our hands and knees. And a couple young adult learners were not making 2 sounds; there were 4. And we actually worked with one little boy, and this is where vision therapy, it's integrating what's coming in visually with the arms and the legs. And his eyes, in the course of several treatments over 4 to 6 weeks, they started coming to a midline position. So that's one example of sensory integration. Others, for an example, a child on the spectrum with the hyperacusis, like loud noises literally give them pain. And it's not that the muscle that dampens outside noise, stapedius, it's functioning, as is tensor tympani, which is more internal sounds. They're fine, they're working. But they're saying their ears hurt, and it's just because it's not integrating. It's perceived as being loud and painful.
So how do these restrictions create that? Like, why is it so if we're having these issues, and you agree that in a large number of these children that have sensory processing issues, which is probably 60% of the camp that I see. So if these kids have sensory processing issues, if they have just an overt anxiety, you agree that a good chunk of these kids actually have physical, structural things that people have missed because they just had no idea how to look for them. So is it that it causes an imbalance in the cranial nerves? Is it an imbalance deeper in the brain? Is it the vagus nerve? Like how do you allow people, or how do you share with people like how they can understand?
Okay, so what I usually do in my practice is I show them pictures of a skull and opened up and show where the little, we call them foramina, holes in the skull through which the cranial nerves exit. And usually there's some kind of compression in those restriction in those openings. So it's impinging on the nerve that needs to come through there. And so it's not there's one area specifically in the base of the skull and the jugular foramen. So deep in there. And cranial nerves 9, 10, and 11 exit through there. So that's the vagus nerve. So those children oftentimes have problems with digestion and their GI system, but also their autonomics, their parasympathetics and sympathetics riding on the vagus nerve. Also, cranial nerve 9 is innervating the palate. And so they have problems swallowing, or they gag a lot. They have feeding disorders, as we call them. And 11 is then doing the nerves of the muscles of the neck. And so they're not able to integrate because the accessory nerve, cranial nerve 11, and the muscle sternocleidomastoid, which allows you to side bend and rotate, is not functioning well with the other side. And so this imbalance is affecting vagus nerve, but if you can help them with torticollis, that side bending, things start to integrate. And then they're able to move their head symmetrically, and all of a sudden you're finding they're not hyperactive or they're not gagging anymore.
Wow.
And so here goes back to a little bit of birth trauma.
Well, before we get there, you just shared so much, and I think for most of the people, it almost went over my head. But for a lot of people, there's so much wisdom that you just touched on. So let's first talk about the nerves that come into the mouth and tongue. So, one of the things that I see in a bunch of these kids is that they have overt feeding issues.
Right.
They can eat, peanut butter and jelly sandwiches, soft crackers, like literally it's just a handful of carbs and everything else causes them to freak out. What's also interesting is with a lot of these kids, if you go all the way back to their history, these were the kids that may have not latched well, they were refluxing, right? So these pieces of history that families share or families may go and look back are all clues that these issues were there all along.
They were.
Right?
They just manifest differently with each age of development of a child. Yeah.
So if a baby is, this is one of my kind of telltale signs that there's some kind of structural issue. If there's a baby that at day 2 to 3 is refluxing, gagging, choking, all of those things, chances are they have a restriction, minus the tongue tie. But they probably have a restriction that's throwing things off, including the nerves that come into the mouth and gut.
And so that's coming from this area, the cranial base. It's a huge area for me to work on because you're affecting all these nerves and the facial nerve and temporal bones and the occiput. So those are the two major offenders. And it's very easy because those bones are in cartilage before a baby's born, and they're movable pieces. And cartilage, by its nature, is compressible. So it gets compressed by nature. These, what we call parietal bones or the cranial vault, are expansive. They develop in membrane. But the ones that develop in cartilage, it gets jammed and jammed. So it's part of the temporal bone and the occiput. And so has the nerves that do tongue thrusting and innervate the facial muscles, and especially this cranial nerve 12, and that's part of the occiput. It's in the condyles, and the occiput's in 4 pieces at birth. And so, depending on what went on during labor, it just compresses it more and more. And that's a tougher one to just expect to re-expand because it's been under pressure for so long.
But basically it's squished. It causes the nerves not to work well, which then causes the mouth
not to function
digestive tract to not function well. How about the vagus nerve? I think this is a really big thing, and a lot of people have maybe heard of the vagus nerve. It's one big monster nerve that goes into the gastrointestinal tract. It's critical for digestion, but it's also the nerve that helps us either be in a state of rest and relaxation or be freaking out, right?
Right.
So sympathetic is fight or flight, something is going to come and kill you, which is actually the state that most of these kids are in, right? They're just hypervigilant. It's like something is going to kill them every day, all day. They can never go into the chill, relaxed kind of mode. How does the vagus nerve mediate that, and how does a restriction here or elsewhere cause the vagus nerve to basically
be on fire?
Yep.
So that is that jugular foramen, deep, deep in there, through which the vagus nerve exits. And it also runs down the back of the throat, so it creates a hypergag reflex in a lot of kids. Some babies, you can't even get the finger in the mouth and they start gagging. So those babies are not going to be able to latch well, because if they put mom's nipple, or if they're bottle feeding, that nipple in the mouth, they'll start gagging immediately. And so then parents do many, many different tricks to try and at least get them to eat, but they'll also present as failure to thrive babies.
Wow.
And the concern is then they go to peds GI and they want to put a tube in their stomach to help them gain weight.
Or we give them high-calorie formula to drink because...
And then they get diarrhea because there's too many, it's an osmotic diarrhea. So why not go and help release the vagus nerve? Now it's coming down the neck along with the carotid artery, so you have a bundle here. And so it's influencing our parasympathetics, and vagus is parasympathetics, and so that stimulates digestion. And it's very calming. It brings the heart rate down. It brings the respiratory rate down. It lowers the blood pressure. The sympathetics will make the muscles tighter. You'll feel a baby with a lot of muscle tone, as if they've been lifting weights. And to them, it's almost like lifting weights. And usually their shoulders are up and they can't relax. And so then we also have to look at the very area through which the spinal cord comes out. And so that's called the foramen magnum, or the big hole. And this is where the spinal cord, and so that can cause a lot of irritability. And so that spinal cord is wrapped in dura, and it basically has little attachments at the top of the cervical spine, C2, C3, and then it doesn't attach to anything with a lot of tenacity till you get to the sacrum, the bottom of the spine. And everything else is just little ligaments, the dendritic ligaments all the way down. So if you can also, if the sacrum gets jammed, it's going to pull on that foramen magnum, and that may be doing some compression, and that causes great irritability.
So if a kid took a bad, gnarly fall, so let's say birth was fine, everything was cool, baby fed well, no reflux, no digestion, but you had a kid at some point, they just took a big fall, which most kids do.
They do. That's
jam
part
up
of
their...
They fall, what do they fall, like 50, 100 times in a year? I mean, somebody's actually calculated how many falls the average toddler takes.
Well, my sister-in-law actually said something really funny. She's like, I believe all babies are born geniuses, but by the time they've banged their heads up so many times, they become normal IQ. It's probably true.
That's a good statement.
They get concussions. But so let's say a kiddo falls, takes a gnarly fall, jams up their pelvis, God knows what they did, throws off this big foramen magnum, right?
Right.
I should know my anatomy, but it's been a few years. And then that ultimately causes tension that throws off the cranial nerves, throws off the vagus nerve, causes them to not function, which then causes the entire nervous system to basically go haywire.
Right. Because it's like a teeter-totter. You have to balance the autonomics. And a lot of pediatric disease processes are an imbalance in the autonomics. Asthma is a really good one. Is like you get, and that has a lot of heightened parasympathetics and sympathetics. And so you have to be able to bring this down. And so these are where some of our treatments are directed towards, is bringing down or just balancing the autonomics. This is really interesting, a lot of ADHD kids, they'll come in and they'll be bouncing off the walls, and I basically will just generate, and I'll put a little pressure back here, it's like a fluid wave towards the front of the skull, and volley it back and forth, and within minutes they're sitting there like this.
Wow.
And it was interesting when I talked about this at our convocation, and it was for children on the spectrum. A couple of the parents who had children on the spectrum went, that's why I instinctively go and I hold their heads, and it calms them.
Isn't
And I
that
said,
amazing?
you don't even realize, as parents, they have an ability to calm their child.
Yeah.
And if I looked at what they were doing, I could explain it neurologically.
It's amazing.
So parents, they have a lot of control over this. Sometimes they just need guidance or direction.
And be given the tools. They need the tools.
And the other thing with this heightened awareness is they can't sleep. So insomnia becomes a big thing.
Gotcha.
And oftentimes people will just will give them melatonin, and all of a sudden they're having other problems.
Yeah, because you haven't addressed the core issue.
Exactly.
So sleep is one of the things that can be impacted if there's a structural issue. And, people do run to melatonin. They do all of these other things, lemon balm, whatever. But they haven't addressed the core issue. If the imbalances are there, how else can it show up? So, you touched on a case you had with ADHD. How about these kids that have OCD, anxiety? I mean, how do you see it affecting the nervous system in particular, but I guess the body as a whole? Because maybe by painting this picture, then parents can look and be like, oh my God, that's my kid.
Right. So again, it comes back to that basic osteopathic philosophy of mind, body, spirit. So oftentimes, they're loving spirits, but their souls are agitated and they're anxious about something. And I had one little boy in clinic yesterday, and nobody knew what to do with him. And they were saying, oh, he must be on the spectrum. And it's not that. It's this little boy was so articulate and so bright, and he had 3 sisters. He was the only boy, and he couldn't sleep. He couldn't sleep at night. And the anxiety in his body, because nobody was listening to him. Nobody was paying attention to exactly what he was saying. And, they were saying, well, he's on the spectrum. And it's like, no. He tries to go make friends at the park, and he initiates it. And he's so verbal and great. But the kids end up not coming back to the park. And so he just has his sisters and his dad showing him video games 5 hours a day.
Jesus.
Electromagnetic fields. Another really, it interacts with the physiology of the body, and it causes tension and anxiety, and it manifests in the musculoskeletal system. And so what my hands are just picking up on is part of the problem, but again, it's a manifestation of what's really going on centrally.
Yeah. If we were to look at this, so if we were to look at how these restrictions can throw off the nervous system, so basically cases of anxiety, cases of ADD, ADHD, I mean, do you even see OCD cases show up like this? So pretty much any of these labels could be a structural issue. Now, if you're a parent, so if you could take off your osteopathic eyes and put on the parent's eyes, from a parent's eyes, how would they know that their child may have restrictions? Because obviously they can't feel it. So let's say our family's in the Midwest or wherever.
Right.
How would they know that their child has a structural restriction that's causing their child's issues? So there's the birth history. So how can you map it out for us so we can see, like, okay, they had the traumatic birth, we touched on that. What are other factors, historical signs that can tell us, like, oh, this kid probably has an issue? Okay,
again, going back to developmental milestones.
Okay.
So you get, and this seems to be the theme of the week in my clinic, is 4-month-olds that can't push up on their arms and can't hold their head perpendicular to the table. They can't hold it at 90 degrees. They're still on their elbows.
They're stuck.
And they're stuck.
They're stuck.
And what's happened, and that might not be it does pretty much come from cranially, but the upper part of the spine, the thoracics, are all flexed over. And it may be very cute, but when the pediatrician says, but they should be pushing up like this, there's a restriction. And then they also don't like tummy time because it hurts. It's frustrating and it starts to hurt. If you were like this trying to lift your head up, you can't. And you can't start reaching for objects because you're trying to balance yourself in this position.
You're trying to survive.
You're trying to survive. And then after 5 minutes, they start crying and their arms are out at the side. And so to be able to release this, and that's what we do in clinic, and they're very proud of themselves, those babies, when they can push up like this. And then the next task is to be able to reach. It's a neurological development. So there's been nerve impingement. So now the next step is to be able to reach for an object. So now they don't have those primitive reflexes and they can open their hands. But if they're stuck under here trying to hold their balance because mom has put me in this position because I'm supposed to be, they can't reach. If they can't reach, they can't extend, and then they can't roll over. So they're not meeting those developmental milestones.
So rolling over, they have a hard time with. Crawling, they have a hard time with. And then I'm guessing they're also late to walk.
They'll be probably, or see, this is the whole body. So we're looking at things, sometimes they'll have, everything's just stuck open. And so their legs are open like this. And because there's this out flare in the hips, which is going on with the same thing with the shoulder blades. So if you see a baby whose arms are held back and then the hips are wide open, they can't tuck things under them to push up either.
Interesting.
So again, you're looking at all that fascia coming from here, and what's created this is, do you have a baby that's all external, we call it external rotation, or do you have one that's all tucked under internal rotation? And so there has to be that balance. So we look at babies that aren't crawling, that they're not rolling on time, and then the babies that they can sit, and so they think, oh, they're right on target. Sitting unsupported 6 to 7 months, but they can't transition over to hands and knees because they're stuck. They're balanced and they're stuck. And so you have to be able to flex those hips to be able to get on one knee so that you can pull to a stand. And sometimes babies that bypass all this flexion and all they want to do is stand at 4 or 5 months of age is because there's so much tension. And that's how they're happiest, but they can't.
Normal.
That's not normal. They don't sleep well. They don't nap well. The moment you put them down for a nap, it's I'm awake.
And then you had also mentioned these older kids are still refluxing. So for me, it's a red flag if you've got a 9-month-old that's still refluxing.
Right.
And it's funny because I had one child and she was actually like 15 months, and then the mom is like, yeah, every time we put her in her high chair, she starts freaking out. And she's crying, and I'm like, I think she's refluxing. So sure enough, she got a treatment, and 1 treatment later, she was better.
Right, because now if you make them sit down, it just increases the intra-abdominal pressure, and if everything's wide open here, or they have other problems, they'll be arching their back and then crying.
Wow.
And it's the same thing, even like you have a 2-month-old, and if you have a 2-month-old, they should be pretty much in this position. If you have a 2-month-old sitting like this, you know they're refluxing. Even if they say they're not having wet burps or vomiting, it's like it's in the back. It's like in the back. They're like this. And so it looks like they're sitting up so straight and they're 2 months of age and it's like, this isn't normal. So you treat them and then they relax. And then they're a lot more compliant and then they tend to fall asleep.
More easily.
Yeah, and even, the anxiety, babies and toddlers, you start treating them and they fall asleep on the table.
So I'm so happy you touched on that, because one of my telltale signs is if the parents are like, yeah, I had to carry Susie, and when she was 2 months old, like all we did was bounce her, and we drove her for 6 hours every day because she wouldn't fall asleep. So the babies that are hard to put down, the babies that are hard to soothe, the babies that you're constantly bouncing because they're colicky, those are actually babies that probably have a structural restriction because they can never relax themselves. And I've seen this where the 6-year-old or 8-year-old or 9-year-old that's anxiety ridden was the same baby at 2 months that was impossible to put down. Same pattern, just different age, except no one made the connection.
Right, exactly.
Okay.
And but at any point in time, we can treat them.
Which is so cool.
Which is the coolest part. Even sometimes into adulthood. It's like they can be treated and then they can continue on their developmental journey through this life.
It's so cool.
Yeah.
It's really a blessing what you do. It really is. And, I really want the world to know what osteopaths like you are able to do for children, because, God, like, how incredible would it be if every child that really needed this care was able to get it? Or at least families knew that was an option. Are there other signs? So let's say now we're in the 2 to 3 or 4 years range. Are there other signs that would maybe have parents clue in that there may still be a restriction? Like one of the things that popped into my mind is if the kid gets an infection on the same side every time, that may be a sign. Are there other things to you that would be clues that maybe there's a restriction there?
That's one of the big ones.
Okay.
And so the line of questioning, and I had such a patient, and it was a little 5 or 6 year old girl, and they were Spanish speaking, and you know, it was simple, otitis media, add-on patient at the end of the day. And then while I'm writing up everything, Dad says, "Why does this keep happening?" And I said, "Well, did she have a lot of ear infections as a child, as an infant and toddler?" No. And I said, "Well, how long has this been going on?" And he said, 2.5 years. And so then you have to play detective. What happened 2.5 years ago? And he says, and you say, and he falls, bumps to the head, and Dad's going, no. Well, she almost drowned. And I'm going, this went from being a simple ear infection to, oh my goodness. And so what had happened, this little 2.5-year-old was an ear drowner, and she hit her head on the side of the pool as she was going in. She was under for a short amount of time. Good news is by the time she got to the ER, she was back to normal.
Wow.
That was lucky. But the whole right side took a hit, so the hemidiaphragm was not working. And the cranial bones, it was an absolute, that dura, it was a strain pattern. And we released it. And then the other thing he said, and ever since then she's been an irritable child. And at school she gets yellow cards and sometimes red cards. And she never gets green cards, meaning she's a good behaved child, because she's just a little angry and she doesn't follow directions and she's not focused. And one treatment, and they came and I followed her, and they didn't know what I was doing. And she laid on the table, and they went along with it. And then she came back a month later. She lays down on the table, and I'm ready for my massage. And that child never ever had another ear infection.
Yeah.
And she's like the top student in her class.
That's amazing.
The best of the best.
That's amazing.
But you sometimes if you see a drastic change in a child's behavior, that's oftentimes it.
Sign that something happened. And you know, part of what drove me to make this Holistic Minds program was that I genuinely believe that children genuinely do not want to be bad. They don't want to act out. You know, unless there's something socially going on, emotionally going on, and that's a whole different can of worms. But that excluded, children do not want to be bad. They don't want to act out. They don't want that negative attention. And for me, when this is happening, it's a sign that something is off balance in that child.
Exactly.
And if we can be smart enough to understand what that something is, then we can give them the rest of their life. Because it isn't just about treating the issues there now. These are the kids that then go on and they maybe can't go into college because they're so distractible. They've got all kinds of learning problems. They got these list of labels, right? And if parents can see that, oh my God, my near drowner that bonked her head, or Tommy's, crash into the tree and something went south afterwards, or the birth trauma, or God knows what.
What happened was done.
Yeah, if these things somehow messed up the structure of my child, which then caused all the nerves to go haywire, and there is an option to treat it, we give them their life back.
Exactly. And even if it's something genetic, because there are a lot of genetic insults, which will add on to this. So be they a chromosomal disorder, or even something as seemingly benign as a scoliosis. That's what I found. A lot of the children with scoliosis, it actually, that curvature of the back, so we always have to make sure it's nice and straight and working well. If there's a curvature, it's going to put more tension on the cranial bones, because it's actually going into what we call a cranial scoliosis. And that's what makes them unable to concentrate. It's like somebody's pulling a cap down over their head.
All the time.
All the time. because that scoliotic curve is yanking sideways. And so, especially during times of growth spurts, it's putting an unequal burden on the growth plates in the vertebral bodies and Wolffian forces. And so what it's doing is it's creating an increased curve, which is putting more tension on the head.
Wow. So if a child has mild scoliosis, it may actually not even be a scoliosis, right? It may be a tension. Right. Same thing with like irregular leg lengths, all of these things. These could all be signs that something is stuck somewhere, which could be ultimately throwing off what you brilliantly said. Oh. So these are all clues.
And I was reminded by Dr. Allen, because I've spoken on scoliosis quite a bit, and he goes, and don't forget all those kids on their skateboards. It creates a short leg, a functionally short leg, and then they can't concentrate. So you get this pelvic obliquity because they're one leg's up and one leg's down.
Who would have thought?
I know.
Seriously.
And there's, I treat a lot of dancers and gymnasts and a lot of kids in the martial arts. And so oftentimes the kados are one-sided and they're very focused, but then they start getting tension in the back. And sometimes they start having problems with their vision or schoolwork.
Wow.
And so we balance them out and they function optimally.
That's amazing.
Yeah.
That's amazing. And, just to maybe touch on the vision piece, because one of the things that I remember you telling me was that if there's a vision error, that also creates a strain in the skull, which then can throw off the nerves, one thing can throw off another thing, which then throws off another thing, which then throws off another thing.
Yeah. So here's an example. So I'm going to use children on the spectrum as an example. And it's actually a known entity called side glancing. So you have a child, and the way the eyeball works is you have central vision, central receptors, and peripheral receptors. And the children on the spectrum, and also some of those with ADHD, they can use their central vision, but they end up using more of the peripheral receptors. Whether that's more, which came first, the chicken or the egg, but the peripheral receptors, so they start using their peripheral vision to look at things. And so maybe they've postulated that that's maybe why they can't read facial expression.
Because they're just checking things out from the side of their eyes.
Exactly. So when they look at you, it either looks like they're looking through you, or they're basically just looking at the peripheral vision on their head. And so if that's how they're actually using their vision and not using the central vision, the eye starts taking that's conformity. So then that dura that I talked about entering the eyeball that's continuous with the sclera starts pulling this way, and you get a lateral strain pattern. So you ask a lot of cranial osteopathic cranial specialists, that's what we see the most often with children on the spectrum, is this strain pattern that's the parallelogram head. Now, here's another thought. Say you had a premature baby and they were in an isolette for 3 months. They end up with that same strain pattern. So they're the ones that are going to end up with ophthalmologic problems.
Because they're just tweaked, especially if they were on a ventilator, they're just
tweaked like that.
Wow.
And sometimes they're restrained, sandbag restraints. So they get this flattened head. And my own daughter was one of them. She was born at 24 weeks. And so she has a lot of visual disturbances, but that strain pattern was reigned supreme. And so then what happens with children with the strain patterns is there are restrictions in the cranial bones, in the temporal bone, and cranial nerve 3. And so they have to use the head motion to look up. So superior rectus muscle. So
instead of looking up,
they're like this. So then you get this craniocervical restriction across the board. So it's a lateral and this. And it's so common and actually pretty easy to work with and correct.
Wow, this is amazing. My mind is blown, and I thought I knew enough. I'm sure the audience has been marveling with all this information you have shared. I'm so thankful.
Oh, you're quite welcome. This was awesome to do this.
Thank you.
Yeah.
And thank you all for watching. Thank you, Dr. Magoun.
You're welcome.